I'd like to ask Pavlos Rouskas to present Desmoplakin Cardiomyopathy. As brief as possible because we are running a little late.
Okay, good afternoon. So I'll go through the presentation instantly, starting the story with our proband. So it's about a 35 years old male patient who came to another hospital for chest pain with a troponin rise up to 1.78 and ECG changes with negative T waves in the inferior leads as well as flattened T waves in the lateral leads. No family for sudden cardiac death, and the patient would complain of palpitations. So the myocarditis diagnosis was done at that point, and then the patient came to our outpatient clinic for further investigation. This is the ECG of the patient, which is with borderline low voltage criteria, negative T wave in the inferior third lead, but nothing else more than that. Here we can see the echo where there is a normal LV dimensions, preserved LV systolic function, and the GLS looks normal as well. So 52 from the MRI, the 52 was the ejection fraction, but the GLS was found less in about -14. We then continued with the LG technique, where you can see there is extensive subepicardial enhancement in a lot of different parts of the myocardium, inferior, lateral leads, posterior, as well as linear mid-wall LG in the IVS. Whereas from the T1 sequencing, there were signs indicating the myocardial inflammation. So the MRI would conclude either or it is an episode of myocarditis, a recent myocarditis, or an acute phase, possibly of not ischemic cardiomyopathy. A SPECT was done before the patient came to us with no ischemia. Holter would show a little bit of ectopics, but from two different origins, as well as an episode of non-sustained VT, as you can see here. A genetic test was done at that point, which was found for this specific desmoplakin mutation, which was concluded as being a variant of unknown significance. We then started looking at the family, first of all with the father, 65 years old, complaining of previous episodes of angina. SPECT would show mild ischemia, but the coronary angiogram was normal. He was on these specific medications. And you can see the ECG of the patient, which is quite abnormal, with low voltage criteria, QS in the inferior leads, as well as negative T waves in the lateral leads. Here we can see the echo of the patient, where we can see mildly dilated left ventricle with low systolic function. Mild concerning LVH only up to 13 kilometers, and the GLS being quite abnormal, being -9%. We performed an echo later, which confirmed the mildly dilated LV with a low ejection fraction, back down to 32%, and there was also mild RV systolic dysfunction with an RVF down to 48. We can see here the LG technique for this specific patient, the father of the proband, where we can see as well there is quite a lot of diffuse fibrosis here, mostly in inferior lateral and posterior wall, as well as mid-wall LGE at the IVS. And a Holter was done on this patient with a high burden of ectopics, more than 2,500 per 24 hours. And it's quite astonishing that there are 3 different origins for these ventricular ectopics, as well as multiple episodes of non-sustained VT, as you can see here on the right part of the presentation. A genetic test was done as well, and there was the same mutation for the father of the proband. We continue with the family. And the mother of the proband, 63 years old lady, with known history of ventricular ectopics, with a high burden up to 34,000 which went down to 12,000 after doing an ablation. No coronary disease, quite symptomatic on New York Heart Association 2 to 3. And you can see here the multiple ectopics on the surface ECG. An echo was done with preserved LV systolic function, mildly increased right ventricular systolic pressure, moderate MR, and mild aortic valve disease. An MRI was done afterwards, where it confirmed the LV ejection fraction of being 52, but there was only a patchy LG enhancement, and specifically the basal inferior post wall, which could be attributed, although this doesn't work very properly, to the aortic valve stenosis. A genetic test was done as well, but it was negative for this specific mutation. And then we went to the children of the brothers and sisters of the program. So the brother is 29 years old, asymptomatic, no medications, no other medical history. And we can see here as well a very abnormal ECG with Q waves in the inferior leads, as you can see here, as well as negative T waves. An echo was done, where you can see here a preserved LV systolic function, whereas the MRI showed an LVF of 51 with a mildly reduced GLS, but here as well again subepicardial enhancement from the related gadolinium technique at inferior posterior, and as well as some linear mid-wall LG at the mid-IVS. And Holter was done afterwards, where you can see here again a little bit, a burden of VPCs, but coming again from two different origins. And the genetic test was repeated again, and it was found to have the same mutation as well as the brother of the proband. And then we go to the sister of the proband, 36 years old lady, also symptomatic, with no medication, no other medical history. You can see here the low voltage criteria, especially in the limb leads. And when we go to the echo, we can see again a preserved LV systolic function, and the GLS being almost normal, minus 19%, with no VPC burden from the holder, and with a normal LVF from the AMR, and no LGE. And as here, the genetic test was found normal for this specific mutation, as said before. And we conclude with the third sister of the program, so a 38 years old lady who did have an admission. So 1 month after COVID-19 vaccination, admitted with chest pain, troponin rise up to 104, and multiple ectopics. So again, a diagnosis of myocarditis was done again. Patient would also complain of palpitations, and she was already on Visopol when she came to our outpatient clinic. And you can see here on the ECG clearly the low voltage, especially in the limb leads, as well as the ectopics coming from two different origins, as you can see here. Here we can see the echo of the patient. So you can see here that the LV systolic function is above 50%. There is a moderate MR, as you can see here on the right part of the screen, which is due to the malcomputation and billowing of the anterior mitral valve leaflet with normal GLS. And when we go to the CMR, where you can see that the LV systolic function is normal, we can see that the lateral and both the mid and apical part of the lateral wall is a little bit thinned, as you can see here with the red arrow. Again, we proceeded with LG technique, and there was again subepicardial enhancement in inferior lateral and apical lateral wall, as well as again the linear mid-wall LGE at IVS. Holter was done again on this family member, and we can see here again ectopics coming from different parts, as you can see here on the screen. and the genetic test would show again this specific mutation which was considered a VUS. So to sum up with this specific family, we've got the proband over here, 35-year-old, who came with a myocarditis episode, and then he was found positive of this specific mutation, which was a VUS. And then when we screened the family, we saw that both father and one brother and one sister of the proband had both phenotype and the same mutation from the gene testing. Desmoplakin cardiomyopathy can have cutaneous form, and this is another patient from our outpatient clinic, where you can see again the low voltage from the ECG, the episodes of non-sustained VT, but there is also skin involvement. So we can see curly hair and the classic palmoplantar keratoma, as well as from the very extensive subepicardial LGE in many parts of the myocardium. So if we go back to the literature, we can see again that desmoplakin is part of a desmosome, whereas along with plakophilin and plakoglobin through desmocholine, interfere and act as a way to provide cell-to-cell adhesion, we could say. And the timeline of this specific cardiomyopathy goes back in 2000, firstly being described with the skin involved as well, the well-known Carvajal syndrome, and then with some kind of families, firstly involving the right ventricle and then the left ventricle involvement, went down to many patients in 2002, and especially giving a lot of significance to the acute phases, to the hot phases, mimicking myocarditis. Here we can see from this review that female can also be affected in even more than male patients. And we can see here that myocardial injury can happen to these patients up to a percentage of 39%. And ectopes are mostly part of the cardiomyopathy, going up to 72% of these patients. Now, from this specific paper from Smith, comparing pathogenic DSP mutation with plakophilin 2 mutations, we can see that patients with desmoplakin cardiomyopathy and LV systolic dysfunction compared to patients with normal ventricular function, non-RV systolic dysfunction, are getting worse. They have poorest prognosis, whereas with plakophilin mutations, patients with RV systolic dysfunction go worse than people with normal ventricular function. From this, again, from this specific paper, we can see there is an amount of patients who have a LV between 35 and 55%, with which they can have a burden of severe arrhythmias during their lifetime. Whereas from this specific paper, and seeing 91 patients with pathogenic or likely pathogenic DSP variants, people with myocardial injury, most of them do have LGE, and as well patients with LV ejection fraction less than 50% have also a lot of burden for LGE. Again, from this paper, we can see that patients who do have all these hot phases, the myocardial injuries, have a worse prognosis, and this is the fact for both ventricular arrhythmias and both for the possibility of them having heart failure during their lifetime. And we'll go to a very recent paper, already reported by Professor McKenna. So 800 patients from the Desperado registry with likely positive variants. And here we can see that these patients, they do have a high burden of adverse events, high hospitalization rates for ventricular arrhythmias and heart failures, quite a lot of myocardial injury episodes. And here we can see the clinical features risk set on the multivariable analysis. And if we take one part of them, this patient that would fulfill the risk criteria from the task force, we would see that many of them, the 77%, will have a frequent LV involvement, high ventricular arrhythmia. The risk calculator would not perform well, okay? And the females would have at least equally high VA risk. So this calculator was created a few months ago, and here you can see the risk factors set in the calculator, and then we can predict the risk in 3 different sections, and we could estimate the 5-year risk. So to end up with my presentation, we could say that patients can show recurrent myocarditis-like episodes of chest pain with documented myocardial injury named hot phase episodes. Extensive subepicardial late gadolinium enhancement can be seen in MRIs, which is often disproportionate to the degree of the LV systolic dysfunction. VPCs are part of the game and the propensity to life-threatening ventricular arrhythmias. And to preface the next session, which is specifically for risk stratification for both pathogenic and VUS variants, we could say that these risk score, along with other potential risk markers, like the high-risk LG pattern syncope, would guide the safe decision-making around ICD implementation. Thank you.
Very good presentation once again, Pavlos.
Thank you.
Do we have any comments, Aris, for this presentation, or because of the late...
Thomas, you can go first. No, I can close this.
we have the microphone in front. We have Thomas.
Well, yet another one condition in which we have almost near normal function of the heart and extensive scar. So this is a question what perhaps towards Professor Sheppard, that classically we know that when there's scar, there's dead cells, and when there's dead cells, there's no contraction. However, in these conditions, we have extensive scar, sometimes ring-like, and there's still preserved function. So I was wondering, what do you see in your pathological specimens that may explain that preservation of function despite extensive late enhancement, let's say, not fibrosis?
Do you know what late enhancement means? You're absolutely right. Because when I see the pathology of these cases, the variation from area to area can be dramatic. I can see normal myocardium next to an area of complete fibrosis. Then I can see an area of complete fat. And then I see an area with half fat, half myocardium, half, 1/3 fibro. The variation from area to area is dramatic. So I can see where you can preserve function because there's still a lot of residual myocardium. So, next to a normal, abnormal, semi-normal. So a huge spectrum, even in the one section. So there's lots for us to compare and correlate the GAD with the pathology, or again with biopsies, although left ventricular are not done. So it explains where the function, because there is still in a lot of them, a lot of residual viable looking myocardium to me. And the other thing about, you talk about myocarditis episodes. Well, I believe what it is you get episodes of myocyte cell death, whatever the cause, and there's an inflammatory response to that, which is autoimmune probably in origin, that it's not what we call myocarditis in the past, and it's something we pathologists are now addressing. We're calling it myocyte injury more than a myocarditis. And the injury can be genetic cause or acquired or combined cause. So lot of questions. We've more questions than answers, haven't we? Thank you.
Okay, Dr. Tsatsopoulos, Adelina.
Very, very nice presentation, a lot of information. And I would like to ask a question. How would you determine the pathogenicity of the VUS variant in that family you reported first? And then I would like to comment on the Desmoplakin family with the skin phenotype.
Yeah, in terms of the VUS, did you ask if how
would you determine the pathogenicity? How would you proceed to determine?
That's a big question, to be honest, because we have a family that was twice reported before this VUS back in 2020, 2022, with a little bit family, of only families, as far as I know. So.
And you still remain to the VUS categorization?
Probably we should.
How would you like to proceed?
Yeah.
How would you proceed with the VUS, seen in so many?
I'm sorry, Adelena. I think we have two different families. In the first family, 3 generations with the same disease, the same phenotype, the same genotype, 3 generations. I think this variant should be upgraded to pathogenic. Then, one family with 2 generations with the same genotype, the same phenotype. I'm afraid that this variant should be upgraded to pathogenic.
And my comment on the skin defects is that this is not the usual type we see when the mutation is homozygous, which is self-speaking. Let's say if you shake hands with a patient with an homozygous mutation, either in JUP or Desmoplakin, you feel, you sense the disease. While in the heterozygous forms, you have to look for, you have to ask him to take off the socks. Yes. You have to look carefully. This is very important to do it because it has not been done. Thank you.
Okay, just a comment. For the whole section. To my mind, we cannot make distinction actually clinically among those different genetic substrates. According to this session, at least, we have in all the patients, we had arrhythmias, fibrosis, and a preserved ejection fraction. We are not able at the moment to be more specific about where is the how is the incubating phase of the disease for its different genetic substrate, and what are the subclinical phase of the disease? Is this the same or not? According to my experience, I see, looking and follow up young people, that they have the gene, but at the first time that I saw them, has not any clinical expression. I saw in the Desmoplakin part that first we have ventricular ectopics, and then follows the rest, according to my experience. On the other hand, in Filamin C, I've seen Filamin C mutation, pathogenic mutation, with circle-like fibrosis with no ventricular ectopics. So I think we have to focus on that. To realize if we have differences in the natural history of those diseases. So far, we do cross-sections examination. We need evolution, the information from the evolution of the disease, I think.
Franco, you seem to be very skeptical. Do you have a
no? Well,
comment?
I believe that this is a work in progress. I believe that we need really to learn a lot. We don't understand why people have this. What Professor Sheppard said, myocardial injury. In fact, I believe that this is not really myocarditis. You find about 10% of our patients that have troponin I, which is elevated, of different levels, by the way. So we don't yet understand exactly how this process is going on. And my personal problem is not really dealing with the patient at high risk, but with the patient at low risk. So what can we do? Do we have data that, how to follow them, what to predict really, what will be their fate? In the case I talked about you on the Phospholamban, for instance, it all, became quickly worsening in 3 years. It passed from hypertrophic cardiomyopathy in 3 years to a dilated and arrhythmogenic phase, and we had to transplant them because he had continuous ventricular arrhythmia burst. So I believe that we still have to learn a lot. So I'm very happy that we are now actually very clever in diagnosing them, but we still have to work on and to see all these young guys that can really follow our steps. I believe that this is really the major goal and the major thing that make me happy.
Okay, thank you very much, Franco. I think at this moment we have to thank everyone, particularly George's Professor Efthimiadis' team that is currently unbeatable. And if it was facing the British team on football, I think UK would lose all the time. Now, I call upon the next chairperson.